My dear postgraduate students, we shall continue with our experiments on the gross pathology of various organs. And the class for the day is small intestine. Small intestine is a little tricky, in which it traverses many an organ or an organ system pathology, and the questions can go in any direction. And you people shall realize that common sense without education is much better than education without common sense. A brilliant saying by Benjamin Franklin. What is important in today's session will be a lot of correlation. You will be crisscrossed in the examination about things that you knew well, could not recollect or answer that fluently at that point of time. So kindly lend me your ears and eyes. Concentrate. The small intestine again for postgraduates. Grossing in pathology. First things first. Whenever we are to jump into any organ for that matter, we would be asked, what is the dimension? What are the parts, etc. And what is the embryogenesis? So here you find that it appears very simple, but then difficult to explain. Extends from the pyloric orifice to the ileocecal junction and is composed of the duodenum, jejunum, and ileum. There is something called the proximal duodenum embryologically and a distal duodenum. This arises in the 5th to the 10th week of fetal life. Later on, the ileum elongates and protrudes into the umbilicus. Look at this relationship over here. It protrudes into it and then again withdraws. But sometimes it can persist to form what is called an umbilical herniation. There is also a counterclockwise rotation. Sometimes this can lead to malformation or to a dextropresentation of the organs. And all this occur with the mesentery or the mesenteric artery as an axis. So these things I would like you people to kindly, these are a beautiful set of diagrams I have retrieved and I have acknowledged the source also. Please do see it. Again, the abdomen is a temple of surprises. Look at what is over here. And my Professor Cooper used to explain what are all the various structures. Remove them one by one. And behind that, you will be finding the kidney. You will be finding the pancreas. In fact, what are the structures forming the stomach bed? Let us go back to the small intestine without any deviation. The main function of the small intestine is absorption. But there is also a good amount of secretion. There will be the acids which are being secreted. The duodenum is a prime example of it. It can be priming you for a peptic ulcer. It is about 25 centimeters and it is circumventing the pancreas, hence the shape I had given. There is a hepatopancreatic duct and there is an ampulla of Vater, which is of great importance in our grossing as well as the Whipple surgery. A sphincter of Oddi, superior, and these are all the various parts of the duodenum. There is a superior part, a descending part, a transverse part, and an ascending part. You will be seeing all this in the next one. So I hope that you people are getting some kind of an idea. The small intestine, it extends from the pyloric orifice up to the ileocecal junction, the first part of it being the duodenum, which is C-shaped, and it has got these 4 components. And also you find that part of it can be arising from the foregut, hence the different shades. The midgut, the last component arising from the hindgut. So there is a large intestine, there is a segment of the small intestine, jejunum over here, and the duodenum. The jejunum is slightly different. You find that these are the dimensions. What you people will have to remember throughout will be the crypts, the epithelial cells and the goblet cells, stem cells and the Paneth cell. I'll be explaining this to you. In fact, I had explained this in detail in one of my classes on the serrated lesions of the intestine. Look at this over here. So there is a superior part, there is a descending part, there is a transverse part which gets ascended, and then finally it ends as a jejunum. A beauty of it is there is no abrupt conversion from the duodenum to the jejunum or to the ileum. In fact, sometimes when a slide is given to us, we have some amount of difficulty in localizing it as the ileum or the duodenum or the jejunum. Duodenum, of course, we'll have to look for the Brunner's glands. And these are all the blood vessels. Have an idea about these blood vessels. The pancreas sitting comfortably within the folds of the duodenum, and the tail ending in the spleen. This relationship, even on the other day, there was a discussion in my college, and the various relationship was asked for, and we could not rattle off that fluently. That is because we are lacking simple things first. So please do look at it. What are the major blood vessels, such as the splenic artery over here, and what are the segments of the intestine, what are the parts of the aorta or branches from which we are getting them. This again appears very simplistic, but very important. As I said, common sense is very uncommon. Any part of the GIT, be it the stomach, the esophagus, the intestine, or the large intestine, you find that there are 4 layers. Look at these are the headings that we people should be having in mind. And when I say layers, it will be obviously the mucosa, the muscularis mucosa, the submucosa muscularis layers, and then the serosa. These are the things in which we have got villi, the lamina propria. And there is a smooth muscle over here which helps in contraction. There is a lot of importance of the smooth muscle in various organs. Identifying the ganglion cells, lymphoid follicles. They are not only for identification, but then for immunological purpose. That again is a function of the small intestine. The mesentery here and the draining vessels. These are important for us. And always we say that there is an inner circular and an outer longitudinal muscle. So whenever we give a section through a particular direction, you will be finding this inner circular and outer longitudinal will be there. Otherwise, it will appear as inner longitudinal and outer circular. So I hope you people have got an idea about it. We have seen the parts of the intestine, and we have seen the duodenum as well as the different layers of the intestine. Going to the contents proper. It is a Pandora's box. The problem is any question can be asked and it can go in any direction. We may be having a simple tumor, or it can be a gangrene of the bowel, but the questions can go in any direction. And these are all the subheadings that you people will have to look for. In fact, one of the videos that I have seen, it was stunning, and I had acknowledged that particular author. So there will be the strictures, the perforation, the polyps, the ulcers that we will have to look for. They can be non-neoplastic lesions as well as neoplastic lesions. And what is the importance of the neoplastic lesions is given in this table. This is what I was telling you people. The layers of it we had already seen. I will not be going into. But then there is a villus. Starting from the duodenum, you have got long finger-like projections called the villi. And they will be having a slender fibrovascular core that is loosely supported by the lamina propria. And the cells on the surface of the villi will be either columnar or they will be goblet cells. Towards the large intestine, there will be greater amount of goblet cells, and towards the small intestine, there will be the columnar cells. These are called the villi. Villi are nothing but projections. So they are projections from the surface, hence the name villi. In fact, from each cell surface also there will be villi, which are called as microvilli. That is why it is said that in the small intestine, the absorbing surface is expanded to several square meters. It is not very simple to do away with a resection surgery. And there is a second component called the crypt. One is the villus, second one is the crypt. And in the crypt, we have got the Paneth cell, the stem cell. So these are of great importance to us, and it is this crypt which is notorious for any malignant transformation. I hope you people are able to correlate the diagrams, and let us see in what way we can apply it. I had been mentioning earlier, it is a temple of surprises. The question for you people can be malabsorption syndromes. Generally, we find it very difficult. It is given extremely well in your Robbins and other books, but then reading it repeatedly is difficult. Hence, I had brought out some pictures for you people. In this, I find that there will be a lot of this foamy macrophages. A bacterial etiology has been assigned to this. And there can be PAS positivity in this. Foamy macrophages. And the surface itself, you find that there is some kind of an atrophy, and it appears like a folded rug or a bare skin rug appearance given in the earlier editions of Robbins. A bare skin rug appearance, foamy macrophages, classical of Whipple's disease. The parts of the intestine, we had seen it earlier. Again, it is being explained. One is the duodenum, two is the jejunum, and three will be the ileum over here. And finally, there is a ileocecal junction. The main functions are, one is chemical digestion, two can be absorption, three can be secretion of the acid materials, and four, which is not mentioned here, can be immunological. A nice saying, common sense is not so common. And we get caught over here. Can you people guess what this particular diagram can be a precedent to? You may be having a specimen of a gangrene or a volvulus. And obviously, they'll be asking you, what is the cause of it? I had explained it earlier in the other classes also. You can go back to it. Please do not omit one. One will be helping the other. So there are the multiple arteries, and I find that they are all bending in the form of an arc. So they are called as arcuate arteries. And from there, you find that there will be the branches which are going in. So if there is going to be an obstruction at any one place, there will still be a blood supply to the different regions. That is the advantage of the intestine. In the chapter on infarct, Robbins says, what are the conditions that lead to an infarct? Some organs have got a dual blood supply, the lung and the liver. Some organs have got rich interarterial anastomosis, and the intestine is foremost. Some arteries are end arteries. The renal artery is a classical example. So in this, what happens is, because of it, the arterial supply is maintained. But still, why we develop an infarct, we people shall be seeing. The various arteries, kindly learn them when you people are free. And obviously, the previous slide will be a precedence to this. Look at the sequence in which I have arranged. Infarct. Always, there are two types of infarcts. Myocardial infarction, we are all very familiar with. There are two types. One is called the subendocardial infarct. Just below the endocardium, there will be a region of infarct. Another one will be a transmural infarct. Similarly, here also, there is a superficial infarct, and then there can be another infarct which is involving the entire thickness. That is called as a transmural one. In any form of an infarct, how do you identify it? Is very simple. The blue color is missing, the pink color is paramount. There may be inflammatory infiltrate. And when you see the intestine, this can happen in any condition. Curling ulcer, a classical example. Shock, burns, etc. There will be superficial ulceration and radiation. All these things. So you find that it has become velvety, reddish, and shiny. Luckily, if the insulting agent is removed, it can regenerate thanks to the crypts, which are capable of immense regeneration. So this is an infarct. Remember, two types of an infarct. There can be a superficial infarct and a transmural infarct. And what are the causes for an infarct? By the way, what is gangrene? There is a blackish discoloration. What are all the points that I can say that in favor of this particular picture? You find that it is stretched. It is shiny. I can see the reflection of the light. So there is an edema. And there is also a blackish discoloration. They have done a surgery over here, and they have left quite a good margin over here. And here it is somewhat pinkish white and viable, whereas the other end is dead. So this can be a case of a volvulus. And this is again the mesentery with not only the arteries, but also the veins. Another example of it can be a strangulated hernia, a volvulus of the intestine. Third one can be an intussusception. Please remember these conditions for a gangrene of the intestine. I hope you people are able to identify it. We have got similar specimen in our college also, but then it is the net that has provided courtesy to Dr. Ashok Sharma for this particular picture. And this I had taken it from Wikipedia, and great is the contribution of the author below. So I find that it is a tangled bag of worms, or if you people cannot identify it, remember this. So it looks like noodles for you. You people can cook and eat it. Ascaris lumbricoides. So you find that it proliferates, it multiplies, it obstructs, and there is also a twisting leading to a volvulus. Obstruction alone is not the thing, but the ultimate culprit, catastrophe, can be because of the volvulus that it can cause. Explain again. And I would like you people to kindly differentiate the small intestine from the large intestine. The large intestine, you find that the folds will be much more prominent, whereas in the small intestine, the entire thickness is small. There is no tags of fat that are over there. There won't be this appendices epiploicae. Tinea coli will not be present. And in general, the small intestine has got a slightly blackish sheen when compared to the large intestine, which has got a more yellowish white or a grayish white hue. And coming to this particular picture, I am seeing this. I am seeing an area where there is a loss of the mucus folds. Loss of the mucus folds. And it is obviously an ulcer. And the ulcer is superficial. I told you the question can go in any direction. Now my question will be define an ulcer. An ulcer is a discontinuity in the lining epithelium caused by the gradual death of cells. And what are the types of ulcers that we can get in the intestine? 1, 2, 3, 4 you people should be having in your mind. One, it can be A superficial ulcer throughout, Clostridium difficile is an example. 2. Non-specific ulcers. Any of the bacterial infections can cause small non-specific ulcers. But in pathology, what we are supposed to be remembering is lesions that will be presenting with classical pathological pictures. Granuloma, as in the case of tuberculosis. Flask-shaped ulcer, as in the case of amoebic colitis. So whenever there is a classical picture, that alone can be asked as a morphology for us, not every other thing. The others are simply called as non-specific. So Clostridium difficile is one. This can be tuberculosis. Third one is typhoid. 4 is amoebic ulcer. These things you people should be able to remember. And here I am seeing something. Apart from the shallow ulcer over here, there is a thickening of the wall. And there is also a narrowing over here. This we will be asked to explain in the exam. Why does it occur so? The ulcer is spreading in a circumferential manner and it is almost perpendicular to the long axis. That is because it spreads along the lymphatics. The lymphatics are circularly or circumferentially distributed. As it is spreading, it will be causing inflammation. It is a chronic inflammatory lesion. Whenever there is chronic inflammation, there is fibrosis. And whenever there is fibrosis, there is thickening. There is constriction. That is why you have got a shallow ulcer that is more fibrotic, and then there is also a constriction that is possible. And another way of remembering it is typhoid ulcer and tuberculosis ulcer. Which one goes in for perforation? In tuberculosis, there will be fibrosis. Perforation is relatively rare, whereas in typhoid, it is one of the most common complications. Typhoid is another lesion that you people should be having in mind. Look at this. Another one. Always, somehow, no, I am not an orderly person. I tend to divert or deviate. So there is a diverticulum. What is a diverticulum? A diverticulum is nothing but a deviation. Even, in fact, you can say the appendix itself is a diverticulum. So in this case, I find that there is an intestine and then part of it is getting diverted out. It happens to be having a blunt end. So it is supposed to be a wormphilo-mesenteric abnormality. There are two types of these diverticula. One is called a true diverticulum, another is a false diverticulum. Think about it. And rarely there is something called as an inverted diverticulum. Instead of going out of the lumen, it can project into the lumen as a polyp. Only thing, it will be hollow inside. Prone for peptic ulcer, and a rule of 2 we will have to remember. You must have read in your surgery. What is the rule of 2? Meckel's diverticulum. 2% of the population located within 2 feet of the ileocecal valve, inches, 2 inches, and occurs around the age of 2. There can be ectopic mucosa, gastric or pancreatic, and the patient can be having a peptic ulcer. Male, female, 2:1 is the ratio. Rule of 2s you people can remember. And this is what I had been talking about. In this case, there is a diverticulum that is going over here. And here I am able to see the muscular layer as well as the mucosa and the submucosa. So this is a case of a true diverticulum where all the layers are. But sometimes when it is going to be devoid of it, there is an absence of the musculature, we can call it a false diverticulum. True diverticulum, false diverticulum. One of the commonest complications is peptic ulcer. Putting it the other way around, if you are going to have a case of a peptic ulcer, they will be asking you, what are the sites of peptic ulcers? Apart from the stomach and the duodenum, you people are supposed to mention conditions such as these, as well as the Zollinger-Ellison syndrome, and so on and so forth. Coming back to our old friend, the villi. Before I go to something abnormal, let me see the normal ones first. So I find that these are all the tall villi, finger-like projections. and the blood vessels are here indicated in red, and there is a loose connective tissue infiltrated with lymphocytes and maybe some plasma cells, classical of it. And look at the epithelium over here. They are all tall columnar epithelium. There are a few goblet cells here and there. This is a normal duodenum that I'm seeing. Lower down, I could see the Brenner's glands. But there is something called as morphometry. Morphometry means you measure the height of the villus, the depth of the crypts, and the number of villi in any one square unit area. Whether they are all uniform, whether they are all blunted or sharp, these are the things that we will have to see. Sometimes you find that the adjacent ones, they almost become merged together and it becomes flattened. These are all indications of an atrophy. Celiac disease is one. You find that it can be because of a food that can be there, wheat protein, gluten or something. And I find that there is a blunting of the villus. It is not as tall and sharp as it is. Obviously, the components are getting lost. And we need not guess too much that malabsorption will be a feature of the celiac disease. Another picture. So as I told you, I can skip. There are skip lesions. And whenever I say skip lesion, it has to be a Crohn's. Crohn's disease can exist anywhere from the anal canal up to the oral cavity. The ulcerative colitis. Colitis means colon. So it is restricted to the colon, though there can be some amount of backwash ileitis. It is a continuous lesion, whereas in Crohn's disease, there will be a skip lesion. A beautiful picture from radiology. Sometimes, I envy radiology nowadays because they are having better imaging facilities and they have literally overtaken the absolute truth of pathology. We can be asked questions like this. What is the morphology? What are the complications? What are the differences? What is the radiological picture? What differential diagnosis can you see? See, when you go for the exam, it is going to be like this. You are going to be surrounded by examiners. Invariably, the external examiner will be asking the question. That is the rule. And the complications are over here. There can be adhesion and there can be some stricture formation, because of which there can be a dilatation, and because of the adhesion, there can be a fistula formation. Ulcer I defined some time back. An ulcer is a discontinuity in the lining membrane caused by the gradual death of cells, whereas a fistula is a narrow tract that connects two larger cavities or a large cavity to the surface. And here again, there can be a narrowing and a thickening of the wall, which can lead to the classical lead pipe rigidity or a hose pipe like rigidity. And what will happen when there is going to be a narrowing and a rigidity? This is what will be happening. You get what is called as a string sign. You do a barium study and you find that there is a narrowing. Try to walk through it. It is not very soft. You find that your heels will have to be pressing on hard pebbles, a cobblestone appearance in the mucosa. And classically, when you go lower down, you are supposed to look for the granuloma. Granulomata will be present. There are other abnormalities that I have covered elsewhere, and people can also be reading up in the inflammatory bowel diseases. But then there is one. Once you get a granuloma, what is your diagnosis? In India, the first three differential diagnoses must be tuberculosis. Tuberculosis, tuberculosis, and tuberculosis. Crohn's disease is relatively rare. Though we may talk about a non-caseating granuloma, so on and so forth, our first diagnosis will have to be tuberculosis. And when we talk about infarct of the small intestine, I've already mentioned the types of infarct. And the various causes are over here. I would like you people to kindly memorize it. I would like to go to this particular picture alone and try to explain it. A volvulus is, it twists upon itself using the mesentery as an axis. And whenever there is a twist, look at the bluish black hue over here. That is because the veins get compressed faster. There is a stagnation. There is a hypoxia or even an anoxia, and a gangrene sets in. The arteries are stiffer than the veins. Veins get compressed faster. So this is the story of the volvulus. And this again is one of the favorite pictures, William Monster, McGill University, worth its weight in gold. A superb specimen over here. And this also Walker. He has to be adorned for this beautiful specimen. It looks almost like a parchment in which I am finding ovoid ulcers along the long axis of the bowel. So there's a long axis and along the long axis. That is because these are all the normal Peyer's patches that you find in the intestine. These ulcers overlie the Peyer's patches and develop. That is why the long axis is parallel to the long axis of the bowel and it matches the Peyer's patches. Classical of typhoid. The question for you people, how do you differentiate the different ulcers? It is not like an undergraduate. As a postgraduate, you are supposed to be rattling off. There will be a point when you cannot answer. That is your end point. A lot of the stories of additions, I already mentioned it, but then whenever it is opaque, it can indicate some kind of an exudate, be it the pleura or the peritoneum, whatever it is. And it can be leading to an obstruction. And the surgeon will be having a difficulty in separating the loops. Perforation can be one of the common things. Sometimes it can seal a perforation also. And when I say peritonitis, it can be bacterial, it can be tuberculous. Sometimes it can be because of chemotherapy or peritoneal tumors. Please remember these four: bacterial, tuberculous, chemo, and peritoneal tumors, metastasis. This particular chart, I would like you people to kindly memorize. No point in me reading it again. What is the disease and what is the pathology of it? Extremely important, simple. When we go to the tumors, these are some of the parameters that you people will have to follow. I have explained it in detail in my class on the large intestinal pathology. You are supposed to be marking the surfaces as blue and black. The cassettes will have to be prepared in this number. From the resected margins, we have to give a shave or even a perpendicular section. Near to the tumor, the mesentery has to be sampled. From the tumor, if it is going to be greater than 1 centimeter, for every 1 centimeter, there has to be a section. If it is very small, it has to be all embedded. And the adjoining or the adherent organs. If there is any other ulcer or submucosal lesion, those have to be sampled. And non-epithelial lesions such as the lymphomas, all of us know the importance and the difficulty in the diagnosis. Tissue can be taken for flow cytometry. If possible, we can take touch smear or imprint smears from the surface. This is a beautiful list. Interpretation of biopsy can be a question for you people. And this can be a useful or a very useful parameter for you people. Polyp, we had again seen. I will not be going into the details of it. So these are the ways by which you classify the polyps. And the question, there can be definitely, every college will be having a specimen of a polyp, a segment of an intestine. What is a polyp? What is a pseudopolyp? When do you call it familial polyposis? What are the syndromes that are associated with it? How do you say that it is benign or malignant? I had taken a class on this polyps also. This, I would say that it's more or less benign, but then this patient happens to be having a mucosa carpeted with polyps. And when it grows larger and when it's going to become more variegated, there are blackish areas, red areas, etc., more prone. And it has to be followed up, biopsied and studied. Lesions need not be restricted to the mucosa alone. Look at this one. It is from the mesentery and there is a nodule. And there can be other lesions that people should be having in mind. Try to recollect. Also in the pictures I would have shown you. So this is a desmoid tumor. Desmoid tumor can be somewhat huge, hard, resembling a fibroid, but it will be paucicellular when compared to a leiomyoma. And catenin will be positive. Another condition is a pseudomyxoma peritoneal. It can be a leakage from the appendix. It can be a real malignancy, or it can be a pseudo malignancy, or it can be, usually it is a low grade malignancy, which by itself is a catastrophe, because that can lead to the spread of the disease much faster. It goes unnoticed. Thanks to this picture from ResearchGate. Non-epithelial tumors. Look at this one. There is just a submucosal lipoma. Could not imagine, but it is still over there. Or there can be other tumors. This is a lymph node that is enlarged. There is a fish flesh appearance that I could see over here. And when I see it microscopically, there is a homogeneous architecture. There are no follicles that could be seen and increased amount of mitotic figures. A non-Hodgkin's lymphoma. Extranodal lymphoma by itself is a question for you people. Galtoma, maltoma, etc. And the associated IHCs you people can read up. So these are all the various methods by which you people will have to cross again. Apart from the tumor as such, you will have to look for areas of induration, any area of retraction, thrombosed blood vessels, mesenteric lymph nodes. Always 10 to 12 is the number that we will have to look for. And open an intestine in the anti-mesenteric border. Avoid cutting it through the tumor because you will not be able to reconstruct it. Any area of luminal narrowing, you will have to see. If it is going to be a polyp, then with the stalk, and the entire thickness will have to be studied. And the resected margins obviously are important. Any area adjacent to the tumor, lymph nodes, adhesions, perforations. And if you do find any other congenital anomaly, that has to be sampled. So this will be the grossing. Have this. Nowadays, you people follow the CAP protocol, so it should not be difficult for you. This is the classical intersusception that we are talking about. Owing to a continuous peristalsis of this particular segment, an absence over here, this goes into it, and that is intersusception. Thanks to ResearchGate. And this again is a lymphoma that is leading on to a volvulus. You find that there is an eccentric swelling, thanks to WebPath. And this is it. So these are the parts of it. So this is called the intersusceptum, and this is called the intersusceptions. And what happens is, this particular region I'm interested in. Whenever there is going to be a loop within a loop, this particular region, the vessels are constricted. Therefore, there is no flow of blood. Therefore, there will be a gangrene that is getting formed. And once the surgeon opens it up, it is not wise on his part to try to undo the intersusception. In fact, he has to do a resection and send it as it is to the pathologist. It is our duty to do the rest. Look at this lesion over here. It is projecting, and this is the mucosa. There is a partial ulceration of the mucosa, but the lesion is not arising from the mucosa. A second clue is it has got an yellowish tinge. This is a classical picture of a carcinoid tumor. It can present because of the various manifestations. It can have the carcinoid syndrome, or because of an intersusception or partial obstruction. So these things you people will have to know. And when you look at this picture over here, I find that the cells are more or less uniform and in a nest-like pattern. There are various patterns over here, and the word carcinoid comes from an organoid pattern. Organoid pattern is classical of any endocrine gland. So, for example, it looks like an islet cell to me. So, it can be argentaffin or argyrophil. Carcinoid tumor is one of the university questions for you people. Again, a lymphoma. In this case, there is an ulceration of the overlying mucosa. Look at this particular one. This is again a polyp-like lesion in which the mucosa is still intact. But here I am finding homogeneous, eosinophilic, acellular material that is over here. The diagnosis happens to be amyloid. That is why the intestine, particularly the rectum, is one area that has to be sampled when a patient is suffering from amyloidosis. And you people should be knowing the stains for amyloid. A nice quote that I derived regarding common sense again. Most people don't realize that common sense is a real thing that computers are missing. In fact, you people would have seen the permutation combination that is possible. Take a specimen of intestine with tuberculosis that is given to you. There is nothing wrong if the examiner asks you, what are the differences between primary and secondary tuberculosis? What are the sites of primary tuberculosis? And so on and so forth. Hence, I would like to conclude that not only the abdomen, the small intestine is also a temple of surprises, and be prepared for such eventualities. Mercy.